All right, with that, I will go ahead and begin. Good afternoon, everyone. I think it's afternoon for everyone by now. Welcome to the Health Equity Roundtable Series, Part 2, the Patient Advocacy session. And today's topics are really, really incredible. They can apply to anyone, and we have an amazing roundtable here today. I want to let you know a little bit about the foundation. So we are a nonprofit in Chicago. We are an affiliate of the Epilepsy Foundation of America, which is where our moderator is from. And we provide free case management and counseling and education advocacy services to people living with epilepsy in the 44 counties that we serve. And this event is actually part of the Health Equity Education Department. So last year we had the opportunity to sort of rebrand the department and really look at some of the social determinants of health and all of the work that we do through a health equity lens. So we're really grateful that you're here. This event is part of a series. In July, we had a roundtable in person. It was called Community Perspectives on Access to Care. And we had an amazing roundtable, which you're able to watch on our YouTube page. And then next week, actually next Wednesday, we have our finale in the series. It's called The Life Cycle of Women with Epilepsy, where again, we're going to have experts talk about birth control, pregnancy and epilepsy, and even postpartum depression and epilepsy in women. So lots of really great topics for everyone to kind of be a part of. I will be turning it over to our moderator. She is going to be introducing our speakers later on. But our moderator, so when I thought about this roundtable, the first person and the only person that came to mind to moderate a conversation like this is Allison Nichol. She is the Legal Defense Director at the Epilepsy Foundation of America. She is a wealth of knowledge. She can answer any question for any person. She has a lot of experience in a lot of the disability rights work that we are going to be talking about today. So without further ado, I'm actually going to turn it over to Allison, and she will introduce our panelists. And what we'll do is after the panelists, all three of them speak, she will moderate a Q&A for everyone. So please use the Q&A feature in the chat. If you need captions, you might have to turn them on your end because I was not able to get them to turn on. I apologize. So go ahead and do that for yourselves. And Allison, without further ado, I'm going to turn it on to you.
Thank you, and thank you for that very generous introduction. Such a privilege to be here today among, these terrific speakers you're all about to hear from. I myself am very anxious to hear about all the great work that's going on. And Chicago is my old hometown, so I'm always pleased to present all the great things that are happening in the middle. So what I'm going to do is I'll introduce the panelists in turn. And we're going to start with Molly Bryant, who is from Legal Aid Chicago. She joined Legal Aid Chicago in 2023 and focuses her work on providing affordable and accessible legal services through legal clinics and community outreach. She received her JD from the Boyd College of Law at the University of Iowa in 2017 and her BS from Iowa State University in 2014. Welcome, Molly. Thank you so much for your time, and I'll turn it over to you.
Thank you so much. Okay, let me share my screen here. Okay, let's go ahead and, okay, does that look okay to everybody? Okay, great. Okay, so I'm Molly Bryan. I'm a staff attorney at Legal Aid Chicago. I specialized in housing previously, but moved into our pro bono and community partnerships practice group, which does mostly legal clinics, community work, and community engagement and outreach. So yeah, let's just get started. So what we'll cover today, I'm covering kind of like our public benefits practice group and what we do and how like the intersection of like being able to access public benefits and what's available. So we're going to talk about benefit types and basic eligibility, IDHS, Department of Human Services, the Social Security Administration, accessing and keeping benefits, which is something that our practice group, public benefits, finds really important, is the accessibility and the continuing access to public benefits, and then current issues and systemic advocacy at Legal Aid Chicago. So just as a note, these are really broad rules and really broad. Public benefits is a huge practice group and does a lot of different work and takes on a lot of different kinds of cases. And while every practice group has its priorities, there's always exceptions. So there are a lot of exceptions. So there are a lot of details we're not covering. Please feel free to ask questions if you have them. But yeah, that's pretty much what we're going to cover today. So just an overview of the benefits at the Department of Human Services. It's also like public aid technically. There's the SNAP benefits, which are food stamps. It stands for Supplemental Nutrition Assistance Program, Medicaid and Medicare, AABD, which is the Aid to Aged, Blind, and Disabled, and then TANF, which is Temporary Assistance for Needy Families. So for SNAP, these are for any low-income person or family. They're technically distributed by household, so households receive SNAP. If you live and prepare food together, you are one household. So if you're living with your minor child and you're also living with your mother. So if I was living with my child in my mother's house, but we kept our food separate, my mother cooked her food separately, shopped separately than I did with my child, that would be two separate households. However, if we bought food together, cooked together, kept our food together, that would be one household, and that would count as everyone's income would count when distributing SNAP to that household. It only covers food, so you cannot buy non-food necessities like diapers, soap, toilet paper, alcohol, cigarettes. You can't buy those things with food stamps. For some reason, they're really able to figure that out. So I don't advise like purchasing anything with SNAP that's not covered by SNAP. They do monitor that. Okay, so when we get into Medicare and Medicaid, which I think is going to be the most important to the Epilepsy Foundation and to people who are working with and like service providers for the Epilepsy Foundation, there's Medicare and Medicaid. So just for the basics, Medicare is an insurance program, and Medicaid is a public assistance program. So Medicaid is the public assistance, the public aid, and Medicare is an insurance program. Medicare is administered by the federal government, the Social Security Administration, and Medicaid is administered primarily by state governments. Medicare is funded by the federal government, and Medicaid is funded specifically by state and federal governments. More providers participate in Medicare than Medicaid. I would say, I think our statistics state that less than 1% of physicians choose to opt out of Medicare. Most are choosing to opt out of Medicaid. I think there was, especially when Obamacare was going into effect, a lot of states opted out of Medicaid, opted out of getting more funding from the Medicaid program. And then Medicare reimbursements tend to be higher, where Medicaid coverage tends to be broader. So like dental care, mental health case management. I think the most specific point there is that there's narrower access to a broad array of services with Medicaid, but there are fewer providers providing those services. So it's kind of like a managed care system where the coverage is really broad, but there's fewer people providing those services in the network. So Medicaid, you qualify as low income if you're below 138% of the federal poverty level. That's like non-elderly or disabled, or 100% of the federal poverty level if elderly and disabled. There's some income exemptions like child support and vets benefits. There's also the Affordable Care Act, which was typically called Obamacare. It's a Medicaid expansion, so it's adults without children that no longer have to prove disability in order to qualify for that Medicaid expansion. And then, as I talked about with the managed care system, again, it's narrower access to a broad array of services. So when you're seeking out services, there are fewer people in network, but the coverage is larger. So it's like mental health, dentistry, primary care, things like that. So that's kind of what the managed care system looks like. And then there's the Medicaid spend down, which is for elderly and disabled people and anyone over 100% of the federal poverty level. So people who may not qualify for Medicaid, they can do a spend down amount, like a deductible, where they spend a certain amount of money and put a certain amount of money into their healthcare, and then the Medicaid would kick in. So that's kind of like this, what the spend down means. Okay, and then there's the marketplace. So it's part of the Affordable Care Act, the ACA. It's for people and families who don't qualify for Medicaid. You can buy health insurance on the marketplace. You're able to obtain an insurance plan even with pre-existing conditions. They can't deny you care or insurance because of your pre-existing conditions. And then there are typically income-based subsidies to help people buy this insurance. It just is dependent on what class you fall into. Okay, and then the Medicare Savings Plan. So for people on Medicare, it's the red, white, and blue card, which is right here in the corner. It kind of looks like that. It's for seniors who are age 65 or anyone receiving SSDI. You can sign up for Medicare through the Social Security Administration. Medicare does have a monthly premium. I think this year it's around $164.60. But if you're low income, IDHS will pay it for you. Otherwise, it's taken out of your Social Security check each month. So you can qualify to get that insurance premium paid for. In order to get Medicare, you can apply at IDHS or Legal Aid Chicago. So my agency has enrollment paralegals, and this is a super underutilized service right now. Our project, so PBPG stands for Public Benefits Practice Group. We have a huge advocacy project on this right now. So if you do have clients who are looking for those kinds of services, or you're just quite like interested in that kind of service, Legal Aid Chicago does provide that service. And I should have probably talked a little bit about what Legal Aid does, but we are a free legal law firm, essentially. You don't pay for any of the services as long as you meet the requirements for our programs. It's typically 150% of the poverty level. But there are a lot of exceptions. So if you have clients and you're not sure who would qualify, you should give us a call, and I will have that information at the end of this presentation. Okay, and then another DHS kind of cash aid is the aid to the aged, blind, and disabled. So it's called AABD cash. It's for people receiving SSI who are probably disabled or 65 plus, or ineligible for SSI because of income. It's generally low income, SSDI, or Social Security retirement. It's essentially a cash supplement for Social Security insurance. And the amount is based on certain expenses. So I would say, like, typically right now, the average amount people are getting who have AABD is about 60 to 70 per month, which can really make a difference in, if you're paying rent, or it's not limited to things like food and like SNAP would be. You can spend it on anything, but they hope that you utilize it for general expenses. It is issued on the EBT card. This is also an incredibly underutilized cash aid assistance program. There are larger benefits for clients with limited mobility who cannot and do not navigate stairs. And then there's also, you could get more if you're an immigrant or a lawful permanent resident. You can get larger AABD cash grants for immigration status reasons. So like if you're an asylee or a refugee or a lawful permanent resident, like those numbers could be higher for you. But yeah, this is something that our public benefits practice group is really pushing right now. We're looking into getting, so I do the legal clinics with Legal Aid Chicago. We have 4 around the city 4 times a month. And they're kind of in different areas. They're located in different areas around the city to be more accessible. And we're looking into getting a way to kind of screen for public benefits needs in general, but also screen specifically for AABD, because we do have so much, there's such a push for AABD cash to be utilized in the city of Chicago. Okay, and then there's TANF, which is Temporary Assistance for Needy Families, and this is for families with kids under 18. There is a limited 60-month lifetime, which is kind of like they say it's a clock. So you start the clock. There are exemptions where the clock stops, and there are work requirements, but exemptions for those. So there's a work activity requirement, but there are exemptions for people with disabilities, people experiencing domestic violence, people caring for ill family members, and then caring for children under 1 year old. So this stops the clock. So, or it doesn't start. The clock doesn't start. So if you have children under 1, or if like you have one child under 1, the clock wouldn't start yet in determining what your TANF is and when that clock starts. Okay. Okay, so these are all DHS programs, and this is kind of how to apply. So you can apply online, you can apply at your local IDHS office. It's typically called Family Community Resource Centers. You can find them at this link. I can send this PowerPoint out if someone wants to share it. If you want to put it like in the comment section of the YouTube that we post this to. And then what to bring. So you're going to bring your ID, social security numbers for all household members, proof of immigration status, and proof of income for the last 30 days, which is typically 2 to 3 pay stubs, depending on the month. And then we also have, at Legal Aid Chicago, we have enrollment paralegals for Chicago residents. It's not all of Cook County because obviously Cook County includes some suburbs, but it's for Chicago residents specifically. And we do have not offices, but we do have locations where our paralegals are stationed. And I can send that information as well. Okay, so something that a lot of people are nervous about, or like that affects people greatly, is the ability to keep your DHS benefits. So every 6 to 12 months, there's a recertification or a redetermination of benefits where you send in any income you're receiving, you send in information on your housing, you send in information on like your family, like if you had children, things like that. And so this every year or every 6 months, they do a redetermination that redetermines the benefit amount you're getting or whether or not you are still receiving benefits. They send this typically in the mail. You must respond and provide information or benefits will stop. Some recertifications are by phone, others are in person, but you typically receive a letter that your redetermination is coming up in the mail, maybe a month to a few weeks before the time that you have to recertify. So you can report changes before the recertifications. I think they're called interim recertifications. If you get a new job, you have a new baby, someone moves out of your home, and you can report that online via Manage My Case on the IDHS website. For TANF, complying with work rules or responsibility and service plan, it's assigned work activities. You have to comply with these rules in order to continue receiving TANF. And that's that temporary assistance for needy families. I know there's a lot of acronyms in this, but I do have them, like I will say them out loud if I remember. Okay, and then appealing DHS decisions. So say you do your redetermination, say you don't do your redetermination, you can appeal this decision if they are canceled or stopped. If you disagree with a DHS decision or there's no decision, typically for AABD, TANF, and like Medicare and Medicaid, it's 60 days. You have 60 days to appeal from the date of notice. So you may get that, the notice may be for February 25th, 2024, and you didn't get the notice till April, like it still would be the date on that notice. So that's something that you would have to prove in the process that you got it late. But typically those get to you within a few days, and then you have 60 days from the date on the notice to appeal. For SNAP, it's 90 days from the date of the notice. If you appeal within 10 days of notice or by date of change, you can request continuing benefits, which means that your benefits will continue during the appeal process. So that's really important to get that done within 10 days of the notice, because if it's after the 10 days, they will stop your benefits during the appeal process. And so you can appeal through that Manage My Case on the abe.illinois.gov website. You can call one of these phone numbers. IDHS it's slow, and they're really hard to get a hold of. Sometimes fax is the best way to get a hold of them, or email. So that's that dhs.bah@illinois.gov. But yeah, if you want to make sure that you have copies of everything, like just from like an attorney brain, like you want to make sure you have copies of everything, pictures of when you sent them, confirmation that you sent them, dates, things like that, to make sure that you're tracking everything that you're doing and making sure that it's within these time periods. So in terms of legal aids advocacy, we're working specifically on Medicare savings programs. Again, that AABD cash benefit, we're working really closely with people in the community to get AABD cash benefits out. Failures to evaluate. So if you appeal and you don't hear anything, like we would nudge them. We would send follow-up emails, demand letters, things like that to make sure that your case is being seen by people. And then we specifically work on the VTTC, which is the Victims of Trafficking, Torture, or Other Serious Crimes, and that's typically immigrants. Violence Against Women Act, which can also be immigrants, but is mostly women, like U.S. citizens, and then other immigrant focused programs. So we're specifically working to make sure that immigrants coming into the city and migrants coming into the city are able to get the cash benefits like SNAP and things that they're entitled to. Because the system can be really difficult to navigate. And it's really important for them to be getting the cash benefits in order for them to survive. So SSI or SSDI. SSI is supplemental security income, and SSDI is that disability insurance. So for SSI, the check arrives on the 1st of every month. For the year 2024, that's $943 a month. So especially when we are evaluating cases that come into clinics, like people come in and they say, I am not receiving my SSI, I'm not receiving my SSDI, I'm not receiving my benefits. And we don't know exactly what they're talking about. These numbers are huge indicators for us as to what public aid they're receiving. So if you see 943, like, okay, that's SSI. If you see sometimes people's checks are like people are pulling from the check. So if the like child support can be pulled from these checks. So sometimes the number is a little bit lower, but you can typically tell like what that would look like. And then the maximum for a couple is $1,415. And again, there are reductions for other income. The SSI is for disabled and people in poverty, or people age 65 and living in poverty. And for SSI, there is no work history required. So anyone can get SSI without a work history. For SSDI, the amounts vary. They can be really high, they can be really low. This is specifically for people who are disabled. There's no asset test, so you can own a home, things like that. Only pensions or workers' comp affect benefit levels. And you do not necessarily have to be living in poverty to receive SSDI. This is insured through work history, and dependents can be paid too, so kids of disabled workers. And our specific work, so we are working on establishing and maintaining eligibility. The SOAR program, which includes focus on HIV clients. It's the SSI and SSDI outreach, access and recovery program. We have people who are specifically funded under SOAR grants to make sure that people living with or are affected by HIV and AIDS are receiving benefits that they need. We're working to we work specifically and we take cases where they are in front of ALJs, administrative law judges, and appeals councils. And then when the process gets to the federal court review, we review those cases as well. We also work to maximize benefits and foster independence, which I think is essentially the goal of any legal aid organization, is to make sure people are getting and receiving and keeping their benefits. So a lot of times people come into clinics, or we have public benefits cases where people are receiving notices of overpayments. Say like recently I had a case where someone came in and during COVID, they had over $2,000 in their bank account. And so the DHS found out about it and sent them a letter that they had been overpaid during that period of time and that they owed $20,000 to IDHS. And so we work on mitigating overpayments, making sure that those were properly calculated, and also during the appeals process. Any return to work questions, and then establishing living arrangements and maximizing SSI benefits. Okay, so can you work and get Social Security? Yes, but you have to report it. Even if you're working temporarily, part-time, or low wages. So say you did like a temp job, you would still have to report that. You can report that by telephone, in person, online, or by mail. Again, make sure you're keeping track of any time you're contacting them. And then, yeah, like key proof of reporting. Impact of work on your Social Security checks depends on whether you receive SSI or SSDI. Again, that's a really nuanced thing. Our public benefits practice group really does a lot of analysis on whether or not DHS is calculating these things properly. Can you work and get SSDI? Yes, but it's an all or nothing kind of situation. So there's a 9-month trial work period. You can where you earn anything, you keep the entire benefit. So you're still earning substantial gainful activity after trial. The benefits terminate because disability cease due to the substantial gainful activity. So if you start working again, you cannot receive SSDI. In 2024, SGA is $1,550 for disabled and $2,590 for the blind, but you can show supported work environment, subsidy, impairment-related work expenses, or unsuccessful work attempts. But there are always ways to get back on quickly if you're no longer working and they stopped your check for work you did in the past. So it's really nuanced. It's something that our attorneys do a lot of work on. And yeah, if you're unsure, you should definitely give us a call or come to one of our clinics. So overpayments, like we talked about, if you receive an overpayment notice, there are 2 paths. You can appeal, which you think, okay, I don't think I was overpaid. I don't think that they're calculating that properly. I don't think that, what is in their records is accurate. You have 65 days from the date of notice to appeal that decision. Or you can request a waiver. So yes, I was overpaid, but it wasn't my fault and I cannot afford to pay it back. That was kind of the situation with the case that recently came into the clinics. You can always request a waiver, and you do have to make your case. And that's why it's important, especially for our attorneys, to be involved, because it's an incredibly difficult thing to navigate. So causes of overpayment, it could be for earnings that you received, money in the bank. Again, I think the limit is $2,000 in your bank account. And then also parents' income if you're a dependent, and then miscellaneous income. So it's kind of like a catch-all for the Social Security Administration is to call it miscellaneous income. So you want to figure out, you want to request records and make sure that they have accurate income notices for you. There are often mistakes in overpayment amounts. So it's really important for you to get records and make sure that they're calculating those things properly. And again, that's where our legal aid attorneys come in. So our Social Security cases, we don't help people apply for SSI and SSDI because there is a large private bar for helping people get approved. Typically, the way that works is you don't pay like a huge retainer up front for these. They just end up getting, so you can get back paid for SSI and SSDI. So say that this private attorney helps you apply for SSI or SSDI, and you get a $5,000 sum of back pay. They would take like 5 to 10% of that $5,000, and that would be how you paid them. And then you would continue to get your benefits moving forward. In order to get benefits after a denial, you have to appeal twice before getting to an ALJ. So it's kind of like an internal process before you get to the ALJ. And And then for establishing benefits, Legal Aid Chicago focuses on people who are HIV positive or affected by HIV or AIDS, or veterans. Also, referrals from our medical legal partners. We have medical legal partnerships. It's like an entire practice group. And then other SOAR affiliated clients. So again, that SSI and SSDI outreach, access and recovery affiliated clients. And that can be from Core Center, that could be from like anyone in the Ryan White program, anyone with a Ryan White case manager. And then, yeah, there are lots of locations around here that have like Ryan White and SOAR case managers. Okay, so how to reach us. You can call our intake line. That is that 312-341-1070 number. Our phone line's open at 8 a.m. I would recommend calling as close to 8 a.m. as possible. Our queue does fill up quickly. You can apply online at legalaidchicago.org/apply-for-services. And then we also have legal clinics and help desks. So this link goes to a page on our website where it gives the locations and times for clinics. The clinics happen 4 times a month. It's like the second Tuesday of the month and the third Wednesday of the month and the first Tuesday of the month and like things like that. So it's the same general time every month. It just depends on like the week. So yeah, so those clinics happen and we do typically get we are typically at capacity on these clinic days. Okay, thank you so much. I am looking forward to questions and I will stop sharing my screen. There we go. Thank you.
I'm totally ensorcelled. I am just in awe of your mastery of these systems. At the Legal Defense Fund, I occasionally get questions like this, and I'm always looking for someone who has more expertise than I do and mastery in this system. So thank you so much. And I know that we will find a way to get all this information out and writing to people.
Yeah,
and
definitely.
Thank you for so carefully preparing that information in a way that would be accessible to everyone. We really appreciate it. And there will be questions. I think we've decided we'll wait till the end for questions and now move on. And do you prefer Steve or Stephen?
Steve's fine.
Steve.
Stephen is when I publish.
Okay, well, there you go. I have the pleasure now of introducing Steve Brown, who was our next presenter. He has an MSW and an LCSW and is a faculty member and holds a dual appointment as the Director of Preventative Emergency Medicine in the Department of Emergency Medicine at the University of Illinois Hospital and Health Sciences System, as well as Senior Director of Social and Behavioral Health Transformation and Advocacy. He has a baccalaureate degrees in business marketing from Northern Illinois University and psychology from Northwestern University, summa cum laude, and a master's of social work from Loyola. And I'm going to, hang on, okay. He is the program director for Better Health Through Housing, a pilot that is raising awareness for the need to recognize homelessness as a health condition. And I, of course, refer to homelessness as a cause of death in this country. Recognize homelessness as a health condition and to scale the nationally validated Housing First model, which we're going to hear about. The program transitions patients who are chronically homeless from emergency departments into supportive housing. And I'm really looking forward to hearing all of the interesting work that you're doing. So please, Steve, go ahead.
Okay, do you see that? I got the right version there? All right, all right, oops, one more thing. All right.
There it is.
Yeah, thank you. And thank you for that introduction, Allison. Molly, while you were doing your presentation, I decided to add a slide to give name to the challenges of working with public benefits. And I'll name that here in a minute. It's also part of the other job that I do. I'm the Senior Director of Business Development at the Institute for Healthcare Delivery Design. And we are bringing consumer product design concepts into the government sphere. Often many of us, we have come to expect customer service as almost the basic human right as consumers in America. And yet we have this disparity of accessing public benefits where it almost seems like people are putting things in our way. And the Institute is helping the state of Illinois address what we call administrative burden. And I'm going to speak about that in a minute. So we're going to define the characteristics of healthcare supervisors, the types of homelessness, a brief description of what Housing First is, and then describe some of the health consequences of being chronically homeless and early mortality, and discuss some current issues regarding efforts to identify, treat, and house persons experiencing homelessness. To that point that I made earlier, I'd suggest everyone read, there's a podcast by Ezra Klein if you don't actually want to read the book. The author's name is Jennifer Polk. She's the ex-CEO of Code for America. And she explains why government systems are often poorly designed and implemented. This idea of addressing administrative burden, or what is also called the time tax, is really beginning to resonate within both federal and state systems. The White Office of Management and Budget has directed federal agencies to identify and address administrative burden. And I'm working with a legislator here in the state of Illinois that explicitly used that language in legislation that was recently passed to remove administrative burden in behavioral health systems. So going after all the bureaucracy and all the clunkiness in public benefit systems that prevent people either from receiving the public benefits that they're entitled to. So I did want to make a brief mention of that. So just a bit about, from my perspective, I've worked in emergency medicine since 2005. I was a social worker at the University of Chicago, both in the adult ER and the pediatric ER, where I conducted child protective services investigations, and my clinical and research interests are in healthcare super utilizers. So when there are upstream failures, they land on our doorstep. And so this is the kind of the perspective I'm bringing. I think you'll find that I think very broadly when it comes not only to homelessness, but mental illness, substance use, and other systemic failures that drive people into our emergency department. This is a fairly well-known concept within healthcare. They're called super utilizers. So it's a person whose complex physical, behavioral, and social needs are not well met through the current fragmented healthcare system. And what we have found about them is that about 75% of their conditions is attributable to one or more combinations of being homeless, having a substance use disorder, or a mental illness. The other 25% are mostly congenital disorders like sickle cell or cerebral palsy. And so what this says to me is that there's much more opportunity within healthcare to have an integration with both not only healthcare, but behavioral health services. And this plays itself out in annual homelessness costs, or housing costs, excuse me, healthcare costs. If you have a common chronic condition, your baseline costs for the year is going to be somewhere between $5,000 to $7,000. If you add mental illness or substance use, your costs are going to double. If that person has comorbidity with both mental illness and substance use and a chronic condition, their healthcare costs will triple to quadruple. And then if they're homeless, it's on average 6 to 10, although we often see some outliers that'll go to 50 times what the average costs are for chronic health conditions. And so in Medicaid, this plays itself out in what we call a power law distribution. So about 5% of all Medicaid clients across the country account for about half of the healthcare spend. And indeed, in Illinois, 5% of all Medicaid clients accounted for about 62% of the total Medicaid budget. And within most states, Medicaid consumes somewhere between a quarter to a third of the entire state budget. I have often wondered, why do we just don't start here and work our way backward? Why don't we focus on this cohort of superutilizers, understand their unique needs, and what kind of integrated care would be necessary, where we could house individuals that are chronically homeless. We could provide integrated behavioral health care services under one roof. Because the savings to a state budget could be significant. In studies that have been shown, up to 42% of the cost of these individuals could be prevented. And when you think of about a $27 billion budget for the state of Illinois, that's not change you find in your couch. That's a pretty significant amount of money. So I'll get off my soapbox now, but I'd like to see more advocacy specifically designed towards these superutilizers. Okay, so let's shift our attention now into homelessness. And let me just start with a couple of precursors here. Let's look at this as not a failure of individual responsibility. In maybe 1 to 2% of the cases, it might be, but the majority of homelessness happens when every other system fails. We need to look at we need to think about this as system failures and not a failure of the individual. And I can, there's plenty of examples that I can give you. But for purpose of brevity, I'm going to have to keep my comments brief. There are 3 types of homelessness. The ones that we most often see out on the street are what we call the chronically homeless in the red box here, but I want to go from left to right. We'll get to that. So in America, about half of all, 80% of the homeless are what we call transitional. It is an equal combination of families and single mothers versus individuals. And for many people, it can be a transitory nature where something has happened. What I used to see at the University of Chicago was, and I can remember this example of a young woman, maybe 25, 26 years old, with 2 kids in tow and 3 garbage bags of her possessions. And what ended up happening was she had a partner that they broke up. She was a single mom. The car broke down. She had difficulty getting it fixed. Ended up getting fired because she couldn't get to her job, was sleeping on her sister's couch for 3 months, and then until they had an argument, they kicked her out, and then she showed up at an emergency department. That person generally gets reestablished. If that person has good resources, they can get reestablished into housing. And in fact, about half of this 80% get back into housing situation within 7 days or within 30 days. The episodic type are generally younger people with some subclinical mental illness or substance use disorder or escalating substance use disorder. About 30% of kids that age out of the foster care system will be homeless sometimes in their 20s too. We don't know that much about this, but I can tell you anecdotally, I see a lot of kids. I used to see a lot of young adults coming into our emergency department that had fallen off the grid because they came from indigent families and didn't have much resources and really needed access to mental health care too. And then the classic homeless that we all know about are the chronically homeless. These folks generally have higher rates of mental illness and substance use and are either sheltered or unsheltered. So they're sleeping at a crisis shelter or they're unsheltered. And unsheltered is any place unfit for human habitation. It's sleeping on a bus, on the L trains, at O'Hare, in a car, in an encampment, or on the streets for themselves. And unsheltered, as you will see here in a minute, carries some very, very significant mortality risks. It's just dangerous to sleep outside. You're prone to the weather and to assault and many other weather-related illnesses that come as a result of living outdoors. In Chicago, this kind of gives you a little bit of a idea of where most of the homeless congregate. And you can see, and this is shifted, and I don't have updated. pre-pandemic, the number one hotspot was the Loop. And if you think about it, it was a source of income for many individuals because they could panhandle there with all of the commuters coming downtown. We know that some of this dynamic has shifted, but haven't been really able to get back to it or articulate it. But you can see other areas here, like on the west side, where there's a large concentration of hospitals. There's the Veterans Administration, there's Rush, Cook County, and UI Health. And about a mile south of here, both St. Anthony's and Mount Sinai. And then Uptown, which has always been it's a very diverse community, but there's always been a high concentration of homeless individuals. And that is a legacy of the Reagan administration not funding community mental health centers. And then on the right here, as you see where there's requests for services for 311 shelter. The face of homelessness is changing. We're seeing people being pushed out of their homes because of low wages, jobs, rapidly rising rents, and employment. And we're especially seeing that in California, where the median home rate and not a lot of multi-unit dwellings is now over $780,000, just inaffordable for most working class citizens. And as we know, I think we've all heard this, 1 out of 3 Americans are living paycheck to paycheck and have no emergency savings. And in Chicago, we're now over the hump on this now. The buses have stopped coming from Texas, but we don't know when they'll start again. But we had about, this is from back when, but we had about 48,000 new arrivals come through the city of Chicago in the last 2 years. And, you know, so a couple other reasons, financial security that I mentioned, zoning laws and local opposition. NIMBY is driving this. Zoning laws here in the Chicago, because of the Great Chicago Fire, are very prohibitive. They need to be liberalized. Everything must be brick. There's a lot of resistance from changes in the zoning laws from some of the trade unions. But the average cost, I heard a number yesterday, to build permanent individual units of permanent supportive housing, the average cost was about $650,000 for a 2-bedroom apartment. So it's just becoming more and more unaffordable. So the Better Health for Housing program, this is the program I've been running since 2015. It is notable because it's the longest running hospital to supportive housing program in the country. We've housed about 130 now since 2015. And because it's such a novelty, we're frequently featured on media. This is transitioned into what's now called the flexible housing pool. And this is a collective impact model, not just an individual hospital. We participate in it now, but we receive funding from the state, from insurance companies, from philanthropy, the city of Chicago and the Cook County. And we've now raised, it's actually 1,400 people have been placed into housing since 2019. We are in the strategic planning to be able to house 1,000 individuals and families every year for 5 years too. So there should be an announcement by the end of the year for that. The next phase of our flexible housing pool has been very successful for us. Sorry, I'm trying to get this to change and it won't go. There we go. So Housing First, as a point of education, Housing First is a unique model that's kind of settled science now, and it has very high retention rates. In the past, we used to kind of use this moral equivalency model, and that's still a philosophy that still is alive and well in America. But under kind of the moral equivalency model, it was, if you do something for yourself, then we'll do something for you. Unfortunately, housing retention rates were pretty low. It was only about 20% of people would be retained within a year. With Housing First, we put no preconditions on it. We just give you a place to live, recognizing that It's impossible to manage your health conditions, to get established, to find a job without the basic stability of housing. And retention rates now are, depending on where you go, they're somewhere between 80 to 90% after a year. So we flipped this from 20% to 80 to 90%. And we see pretty substantial reductions in healthcare cost and utilization when people have the stability and the dignity of having a place to live. It's generally scattered site housing. We don't put people into congregate settings. Often people have comorbid mental illness and they don't do well in social situations. They really just want to be by themselves. It's not a group setting. And we take a third of their income, no matter what their income is. So if it's $30, we take $10. So let's talk a little bit about the health consequences of being, and I'm going to wrap up here so I'm getting a little bit over time here, as a dangerous health condition. These were statistics we had on our first cohort of 26 patients. This is pretty representative of the homeless population. And you can see very high rates of chronic diseases, asthma, COPD, hypertension, kidney disease, diabetes. We actually had a very high rate of cancer because many people that are unsheltered smoke, or they're using, they smoke and they drink, and there's an effect called attenuation that can cause heightened rates of cancers in people that use both. Also, a hidden epidemic, and this is one of those chicken and egg things, is that a large paper in Canada found that about up to almost 3/4 of the chronically homeless have neurocognitive deficits, including epilepsy and uncontrolled seizure disorder. And so we don't know if this is a precursor. Was it a football injury that happened to a kid playing, football back when they were 18? Or is it a result of living on the street? So nearly 50% have evidence of a traumatic brain injury. But we know that it contributes to people being able to be reestablished and to be able to navigate some of these complex systems to get back into care again and back off the street into stable housing. Mortality also tends to be very high with this population. And it's age related. You'll see it declines on the right here to 0. That's because there's an increasing mortality rate of the population over at the same time, and it intersects at some point. But we can tell you that unsheltered mortality rate is 3.6 times higher than all homeless people that are sheltered. So it's a pretty dangerous health condition to live. And so why are the chronically homeless so expensive? Because we managed to shift the costs to the most expensive beds in town. Instead of paying for the housing of about an average about $57 a night, we shift this to emergency room and inpatient hospitalization. So, we did an analysis on this, and if you look at the total costs, and then look at the annual, the per night cost of a magnificent mile hotel, you can see that we might come out ahead even if we house them. I actually used the name of one of the hotels. They politely told me to take their name off this slide, which I don't mind. And this is what we call, I won't go into this, but this is, if you look it up in social service research, it's called the wrong pockets problem. We have a realignment of the money. UI Health is not paid to do this. We don't get reimbursed for it. We do it because of our health equity mission. It's a money loser for us because we're not compensated for it. And yet, insurance companies, the state, not only in the carceral system, but the court systems and with insurance, with Medicaid, really benefit when we house these individuals. And so we've got a classic wrong pockets problem here. We don't get compensated for it, and other state entities benefit from us doing the housing for them. And I've mentioned this one before. I've got like 2 more slides here. We'll be wrapped up. But let's look at a little bit at the upstream structural determinants. I'm just going to take a minute on this. So upstream determinants that contribute to homeless, the city has failed to adequately fund the city's shelter system. I did a Freedom of Information Act request, and we found that, if I'm being generous, because the data was not very good, only about 1 in 4 people that request shelter are actually getting into it. And we need to make a commitment to more affordable and supportive housing here. There are a number of reforms being put together by the Department of Housing at the City of Chicago that would include some of those zoning reforms we talked about. And we need to divert people away with mental illness and substance use from engaging with the criminal justice system. There is a move afoot across this country called 988 that is beginning to address those things. And, you know, this is a little nerdy, a little policy, but a little down in the weeds, but we need to have an integrated payment stream for both mental illness, substance use, and healthcare, because it's so hard for providers to get paid. And the administrative burden of just trying to do the right thing can be overwhelming for many nonprofit agencies. So with that, I will wrap it up and we'll defer questions to later. Thank you.
Thank you. That was completely brilliant. I really feel like I could sit and talk to you for a few days about many of the points that you made. I'll just talk about a couple. I didn't, as someone who works at I've been generally a disability generalist, but now work at the Epilepsy Foundation. I was completely unaware of the level of neurocognitive impairment as well as TBIs among the homeless population. I don't really think that that is nearly well known enough. So thank you for all of that incredible information and for presenting it in such a way that's so accessible for those of us who are not, you know, not expert in this. And thank you for all the amazing work that you're doing. I'm certain as I sit here that you have saved more than one life through this program. And I look forward to asking you some questions and having more conversation a little bit later. So thank you very much. And now it is my distinct pleasure to introduce our third and final speaker, Kate Polk. She works for one of my favorite organizations in this world, Access Living. As any disability rights person will tell you, that is, you know, an iconic name in disability rights. And Kate joined Access Living as a staff attorney in January of 2024. So she is newly minted there, although not a newly minted attorney. She focuses her work on enforcing the fair housing rights of people with disabilities through litigation and also policy advocacy. And Kate, I'm really looking forward to hearing what you have to say, so please.
Thanks so much. I'm going to go ahead and share some slides I have. Also, a heads up to everyone that there's some interactive components, so get ready to participate. Okay, so Allison has kindly introduced me already. I just want to start quickly by explaining what Access Living is and what we do. So we are what's called a Center for Independent Living, or a CIL, which promotes the independent living of people with disabilities. And we are unique in that space because we do have a legal team. And so in addition to individual cases where we represent individuals in disability discrimination cases, we also do systemic litigation. We have 2 different cases against the city of Chicago right now, one for the inaccessibility of their shelter system and one for having built inaccessible, affordable housing. So we do all kinds of cases, all kinds of litigation, all with a disability discrimination component. Our quick agenda, we're going to go over what we refer to as some major housing barriers, then some basics of the Fair Housing Act, and then we'll get into some hypotheticals, mostly about reasonable accommodations and reasonable modifications, where everybody will get to weigh in on some things, which I think is a really great way to learn. So, like if you want to just take a minute to think what you would imagine the 3 major housing barriers for people with disabilities are. We refer to the first one as affordability. So people with disabilities live in poverty at more than twice the rate of people without disabilities. And for many years, people with disabilities have been employed at less than half the rate of people without disabilities, not only because of what someone is able to do, but also because of disability discrimination. So there's many individuals with disabilities that rely on supplemental security income, which Molly taught us all about. And that's unfortunately kind of a low number to be able to afford an apartment or housing, etc. It's in Chicago, the average 1-bedroom rents are over 150% of the SSI benefit level. So it's economically out of reach for a lot of people with disabilities. Second, we consider accessibility to be a major housing barrier. So less than 5% of the nation's housing stock is accessible to people with moderate physical disabilities, and less than 1% is accessible to people who use wheelchairs. And increasing that problem is that accessible housing is more expensive than inaccessible housing. So typically it's in newer buildings if there's an elevator, and those are going to cost more than older apartments and walk-ups. And then the third barrier that we go over is discrimination. HUD's, the Department of Housing and Urban Development, did a 2015 disability discrimination study that found that people who are deaf or hard of hearing and people who use wheelchairs confront discrimination at a lot of different various stages throughout their housing search. And well-qualified home seekers who use wheelchairs are more likely than comparably qualified home seekers to be denied an appointment to view or be denied in other ways. And it's the highest percentage of HUD complaints. So there's the Department of Housing and Urban Development does discrimination, like they evaluate discrimination complaints, and the highest percentage of those complaints are disability discrimination complaints. But there are fair housing laws and other disability rights laws that can help try to level the playing field. So the Fair Housing Act, it was passed in 1968. If anyone remembers, that was shortly after the assassination of Martin Luther King Jr. And the original act covered race, color, religion, and national origin. And then it's been amended in 1974 to add gender, and then in 1988 to add disability and familial status as protected classes. Also, the city of Chicago and Cook County have their own ordinances that prohibit discrimination based on those classes and on additional classes like source of income. And the state of Illinois has a source of income discrimination provision as well. So the act added affirmative obligations for housing providers in addition to what a housing provider cannot do, there's also what they must do, and that is reasonably accommodate people with disabilities and do reasonable modifications for people with disabilities. And then new construction, there are certain attributes that new construction has to have, certain percentages of it have to have these attributes to be physically accessible. And then for the sake of time, I'm going to skip, but the important thing about this rule, about Section 504 as it applies to fair housing, is who pays, and we'll get into that in a hypothetical.
And let me just say, you have plenty of time. The
Okay,
floor
great.
is yours. You do not need to rush.
Great. So everybody get ready. It's our first hypothetical. So our first is going to be about Peter. And Peter shares custody of a dog with his ex-wife. He lives alone in a building with a no pets policy. The building told Peter he cannot keep the dog. Peter claims the dog provides emotional support that diffuses his anxiety and obsessive thinking, especially at night. And Peter is a teacher and a part-time actor for work, and he does not take his dog to work or when he's acting. So what thoughts do we have about this? Do we think the fact that he shares custody of the dog is an issue? What about the fact that he doesn't take his dog to either of his jobs? What about the fact that he needs the dog most at night?
I feel like shared custody might be a big issue, because if he doesn't need the dog at every night, or if he doesn't have the dog every night and it's not serving that purpose all the time, that might be an issue.
Yeah. So this is based on a real life client that one of my colleagues had, and that was his first concern. And so he asked, like, what do you do when you need the dog and the dog isn't there? And he said, oh, well, like my ex-wife lives nearby. I give her a call. I ask her if I can come get the dog, and then I just go pick up the dog. So, and I apologize, I can't see comments.
Oh, I was just saying if folks wanted to participate in the chat, they can feel free to type in a response.
Yeah, that would be great. And then if somebody could share, oh wait, let me see. I can
Yeah,
find it.
we'll monitor that chat for you.
Okay, great. Thanks.
And I agree. I
And
think the shared custody could be problematic. I think you were talking about how he
yeah,
gets
oh
the
yeah,
dog
yes.
back and forth with his wife.
Yeah, and then in exploring more about why he felt he needed the emotional support animal, it was really because he's alone at night, and then that's when his intrusive thoughts come in. That's when he really needs that support. He goes and gets the dog when he feels that and the dog isn't there, and then he doesn't feel those same types of concerns during the day when he's around people teaching or when he's around people acting. So all this to say, he does deserve his emotional support animal, and he was successful in keeping his emotional support animal.
Well, that's some pretty spectacular lawyering, because I thought this case was going the other way. So good for you.
Thank you. That was my beloved colleague, Ken. So I'll send him your regards. So the next thing to discuss is, can Peter just say to his landlord, hey, this is what I'm going through, and so I need this dog? And is that all he has to do, or does he need to provide any other kind of documentation? What do we think? Is Peter's word enough, or does he need documentation? If you want to just put in the chat and say Peter's word or say documentation.
People are voting documentation.
Yeah, and people are right. So typically the rule is that if it's something that is like an invisible disability, then having documentation is important in supporting that and making it a strong and legally defensible request. If it's something that is more physical, like I'm in a wheelchair, I need to use an exit that isn't allowed to be used normally, like I'm going to ask for an exception for that, then you wouldn't need to provide documentation to prove that, because it should be obvious because of the physical nature of your disability. The other thing about documentation is that it just needs to be from a knowledgeable medical provider. So it doesn't, or someone who's familiar with your situation. So it doesn't have to necessarily be like your primary care physician. It can be like a therapist. It can be a nurse. Like, you know, there's a wide variety there. And that their documentation should connect your request with your disability. So explain why this request will help you, but it does not have to disclose your specific diagnosis. The next question is, does the dog have to have specific training to be an emotional support animal or a service dog? Or is me saying that the dog does this and the dog actually doing it enough? Yeah, so definitely no training needed for emotional support animals, and also no specific training needed for service animals as long as that animal does what I'm saying it does. So if I have a seizure disorder and my dog is trained to like notify me that one is about to happen, even if I'm the one that trained the dog or my brother is the one that trained the dog, that's enough. It doesn't have to go to like a special school to be trained in that way. Next question is, can my landlord charge me pet fees, pet rent, any kind of additional deposits, any kind of extra things for my emotional support animal? No is correct. If they do try to charge you for that, that is disability discrimination. A lot of people don't know that, and because it's not typically that much, I mean, it's significant, but people will be like pet rent of like $10 a month or like a one-time pet fee of whatever. People don't necessarily think that that is not allowed, but it is not. So pro tip for you. Next do size or breed limits still apply to emotional support animals? Yes or no? No is correct. So even if there's a size limit of 50 pounds and you and your dog is 70 pounds, like you are allowed to have your emotional support animal or your service animal. Even if your emotional support animal is a pit bull, you are allowed to have that animal. Can there be any restrictions on the dog? Like, can your landlord say, okay, fine, you can have the emotional support animal. I won't charge you pet rent for your dog, but your dog is not allowed to be in the common areas, or your dog is not allowed to be in the yard? No is correct. So your dog, if your dog is your service animal, which is a term for both emotional support animals and and other like more traditional service animals, then they can go where you can go in your apartment premises. And then what if the dog is poorly behaved? And this can mean, you know, what does that mean? What we normally think of as poorly behaved, like, you know, dogs bark. Your emotional support animal is allowed to sometimes bark. Can they bark like constantly 24/7 and destroy furniture and the apartment? And can they bite people and can they bite other dogs? No. But they're allowed to be dogs. Like they can bark when someone walks by the window, you know, that's fine. And then what about other animals? So we've been talking about dogs so far, like, can I have an emotional support cat? So the answer is that my emotional support animal can be a cat, but cats cannot be service animals under the ADA. So the Fair Housing Act is a lot more expansive about service animals and emotional support animals, whereas the ADA, I think the only two service animals in the ADA are dogs and miniature horses. Okay, so dogs and cats, yes. What if we go a little bit less traditional and we want a ferret? Can I have an emotional support ferret? So you'll be surprised to learn that one can have an emotional support ferret. Now, it does get harder the more exotic the animal is. So I think there's been like some stories in the news about like emotional support peacocks and emotional support alligators. Like that's a lot harder and maybe not legally defensible, but emotional support ferret, yes. Okay, and then one other thing about emotional support animals is, can you have more than one emotional support animal? Yes, the answer is yes, though probably not more than two. I think some people that might be approved on a case-by-case basis, but it is less defensible to have more than two emotional support animals. You know, the more you try to say are your emotional support animals, the tougher it is going to be to defend that, or prove that or get permission for that. But fun note about ferrets that I learned is that ferrets are best had as pets or emotional support, etc. They live their best lives with a friend. So so really, I guess in the ferret world, you're supposed to have two ferrets so that they can enjoy life together in the best way. So you can almost definitely have two emotional support ferrets for that kind of reason. But important note, you cannot get an emotional support animal for your emotional support animal. So note to self on that one. Our next hypothetical is about Jared. Jared has a mobility disability and needs an accessible apartment. He received a housing choice voucher from the local public housing authority, and they've given him 90 days to find an apartment. So even though he's looked diligently for an accessible unit that he can afford with his voucher, he has not yet found one, and his 90 days are about to run out. So what can Jared ask for as a reasonable accommodation to help him. Molly is right on it, showing her housing knowledge. He can ask for more time. He can ask for an extension. He can explain, like, I have this disability. It's made my housing search hard for XYZ reasons. And so I need an extension to find more time. I mean, I need an extension of more time to be able to find an apartment. And that is a reasonable accommodation, just like the emotional support animals are. I guess we'll skip questions to the end. So those are my reasonable accommodation examples. And now we're going to talk about modifications. So typically we think of reasonable accommodations as being a different, like either bending a rule or making an exception to the rule, or something that accommodates you, like, making an exception to the no pet rule, making an exception to pet fee rule, like making an exception to your voucher expiring at a certain time, etc. But modifications are more physical, like physically changing a unit, physically changing your surroundings. So an example of that here is that Keisha has a physical disability. She has lived in her apartment building for several years. Until recently, she relied on a cane or walker to move about. However, her condition has become worse over time, and now she uses a manual wheelchair. Because of this, she has difficulty getting through the front entrance to the building because it has a step. So she would make a reasonable modification request for a ramp. And then we need to figure out who's going to pay for this ramp. So do we think Keisha pays for the ramp? Do we think the building pays for the ramp, like the property manager, the owner? Do we think the government pays for the ramp? Do we think whoever installs it just doesn't charge?
I would say the landlord probably pays for the modification. I hope that's right.
So you will be very disappointed to learn that in
Clearly I know
private-
nothing about the Fair Housing Act. I'm a disability rights expert, and this is all news to me. Okay, please go ahead.
In the private market, so when you are the one responsible for paying your rent, any physical modification made to the unit or the building, you are technically responsible for. Now, sometimes you can make the request and the landlord will agree to pay for it, but legally, there's not a way to force them to pay for it. Okay. The exception to that is if it is if the landlord receives federal funding. So if it's a public housing development or a project-based Section 8 development or other kinds of site-based developments, then they are responsible for paying for the modification. Unfortunately, the exception to receiving federal funds is voucher holders. So even though the owner of a unit that is rented to voucher holders does technically receive federal funds because the housing authority pays a portion of the voucher holder's rent, the voucher holder is still technically responsible for paying for that modification to their unit, which is very difficult to practically manage because, like, by definition, if you have a voucher, then you don't have a lot of spare money lying around to pay for a ramp to be installed, to pay for the bathtub to be converted to a roll-in shower, etc. There are some, like in Chicago specifically, the Mayor's Office of People with Disabilities does have a fund that can help both renters and homeowners with paying for modifications. But as probably everybody has guessed, that fund is used up pretty quickly. And then you have to wait for the next round of funding to come through in order to fund more.
So Kate, I'm going to have to exercise my moderator's privilege here. You've given us so much rich material, and I know there's more, especially around policy modifications. But, we've been given so much terrific information. I find us with only about 5 minutes left for our audience to post questions and for me to post questions. But first of all, thank you. I clearly have to study more about the Fair Housing Act. I will say one thing through moderator's privilege, and that is especially when you talk about emotional support animals. There are different rules, as we talked a little bit about. Fair housing is one, public accommodations is another, but also the Air Carrier Access Act, which has made very recent changes to the rules around transporting emotional support animals. So if you have a person with a particularly emotional support animal, I think you need to be aware of that. And thank you so much, Kate. And so I want to, we have a little bit of time left. I had a bunch of questions, but I think actually on the fair housing questions I was going to ask Steve, and you did such a terrific job. I don't really have those questions anymore. But I do want to pose one housing homelessness question. The past 3.5 years in my mind has been sort of a golden age for disability rights regulatory work, right? We've had the first new 504 reg in 50 years. We've had the 1557 regulations, new Title II rule under the ADA, and more to come, the new rights of way rule. So my question is, we have had a less than friendly Supreme Court, and have you seen any practical effects in the city of Chicago of the Supreme Court's ruling in Grants Pass? And for our audience, that's a case in which the Supreme Court essentially ruled that it was okay for Grants Pass, Oregon to criminalize homelessness there, including not just through incarceration, but also through fines. And I think probably Grants Pass is really not looking to incarcerate a bunch more people. They just would like their homeless population to go somewhere else. So just a quick question, have you seen any impact of that in your community?
So not in Chicago explicitly, but what we did see during the DNC was a kind of overtly political move to relocate the encampment at Roosevelt and the Dan Ryan Expressway under the auspices that they actually were transferring populations. And so they moved them into the Tremont Hotel and displaced people that were new arrivals there then. So it was a zero-sum game.
Right.
And to me, that was just optics.
Yeah.
That was done by the Commissioner Brandy Kanazi.
Okay, all right. So I'm going to give you something you've never had before. I'm going to give you each the magic public policy wand and 3 wishes that you get to make for public policy changes that would improve the lives of the people that you see every day. And you can't choose money, because we all know money is a big ingredient in this. You have to choose something else. So I'd like you all to have some chance to do that. So I'll start with Kate. Quickly, 3 public policy wishes from you.
Okay, well, my first is more affordable housing, more public housing, and that it be better. My second is more accessible housing, physically accessible for people with mobility disabilities, but also people with vision or hearing loss. And then, well, my third one was going to be like a universal basic income, like giving people money instead of
okay,
all the strings attached.
I'll let you sneak that in under the wire. That's good.
Thank you.
That's good. Thank you. Molly, quickly, 3 public policy wishes for you.
I was just writing them down. I would also say free, like affordable housing would be a huge one. Free school lunches. And the third one, maybe more job training, like or less requirements for jobs on the market. Yeah.
It's great. And I think employers are moving away from the necessary college degrees in many of these jobs, which is very welcome change. Steve, quickly, 3 public policy wishes for you.
Yeah, transfer the responsibility for the homeless system in the city of Chicago from the Department of Family and Support Services to the Chicago Department of Public Health, recognizing that it's a public health crisis. 1. 2 is reform building code regulations to make it more liberalized and easier for developers to break ground. And kind of a money thing, I'm going to sneak this one in too.
Okay.
Some subsidies to make it easier for those mission-based affordable housing developers to launch their projects by escrow accounts and by assistance with purchasing market rate properties to be held in escrow until they can get their capital stacked together. A little nerdy, but that's my stuff.
So since I'm like the mid-century modern person on here, I will, and therefore the most wily, I will say my first wish, of course, is for unlimited wishes. And then I don't have to make choices. So just keep that in mind if the genie ever comes out of the bottle.
Smart.
I want to thank each and every one of you for all of the work that you do every single day in your work. You work hard in the service of others for a cause greater than yourself. And I would include all of the people at EF Chicago in that. And I really want to thank each of you for doing that. That is both notable and rare and to be commended.
Great.
And then with that, I will toss it back.
Thank you all so much. So much information here. And so just as a testament with how much space we have, so how much work we have to do in this space, and just I'm really excited about what's next. And so hopefully we can have more iterations of this topic. And of course, this is going to live on YouTube. So hopefully this will just be the beginning. But thanks to all of you for sticking around for this amazing webinar. And thank you for your time and your support. So with that, thank you so much.
Thank you. Thank you,
Bye,
everyone.
everyone.
Thank you.